It's now my pleasure to introduce two fireside chats. I'm going to hand over to Carol Nowina, who's Executive Director of Sitam Plus, long-standing diagnostics champion. Thank you so much for being here. And also to Blessy Kumar, CEO of the Global Coalition of TV Advocates. So they're going to read us through the rest of the session for this morning. Thanks so much.
Good morning. Carol and I are very old community advocates. We've been working together for the past 16 years, I think. So we've seen the landscape change, and we do hope that we would be able to light some fires here today, Carol. So thank you very much for inviting us.
Yes, thank you very much for inviting us. I'm really happy that the community is actually now brought to this space. We are hoping whatever fire we brought in HIV and TB, we are hoping to bring it to the diabetes and TB co-infection space.
Okay, so we're going to ask each other a few questions, pointed questions, and we hope that the answers will inspire you all. So Carol, you know, you manage a huge organization in Zambia. So how does a lack of integrated care impact the experiences of affected communities, and the outcomes and the cost?
I'll use my experience. So I'm a person living with HIV and TB survivor, cancer survivor, and now someone with diabetes. So services, I come from a country in Africa called Zambia. The services are in different areas. For example, you have a TB clinic in a certain area. Diabetes, if I have to get my diabetes services, I have to go to a different clinic. That takes up, a lot of my time and also the cost. And these clinics are not open or available every day. So, for example, I have a family, I have maybe a farm, a garden to farm. I cannot go there because then today I go for my diabetes. Maybe I take the test, they tell me come and get your results tomorrow. Then I have to go for my maybe TB treatment. I go. So the whole week, I'll end up spending the whole week. And sometimes the facilities are so full, so I'll be there the whole day. I have to pay money from one facility to the next, and then I have to have lunch. I have to also leave maybe money from. Yes, so blessed, that is what becomes a problem to the point where I might as well just stay home sometimes to avoid the costs.
Yeah, thank you.
So for you, again, you also run the global the GCTA, which global organization. So for you, what would be an ideal model of integrated care? What would that look like to you? And what might ideal models differ between patients from your perspective?
Yeah, thank you, Carol. So I'll pick up where you left off and build on it a little bit. I think, we've heard about the comorbidity, the figures, the facts, and how diabetes and TB are correlated. So then the question is, why aren't we bringing the services for people on the ground together? We need collaboration. We need, like what you mentioned, a one-stop shop so that you're not running around. But we also need policy change. Working at one level is really not going to help. You need people who are making the decisions to be convinced that this is important. And we also need funding. The information we have today perhaps is not adequate. We need more research. So integrated service delivery, integrated models can only happen if these things are put in place. And the overarching thing is advocacy. Advocacy is very important at ground level. And I'm very glad that you and I are invited here, but I think much more engagement of the community is extremely important for an ideal, may not be ideal, at least for a workable, good, integrated service delivery model. Communities are closest to the people. You and I live in the community. We have the lived experience. And we know how to talk to our leaders at country level, the community level, in the health ministries. So I think it's very important to bring that aspect of advocacy. And communities also need to understand. So there needs to be awareness. There needs to, in a language that they understand, community tools need to be developed so that our communities are well equipped and understand so that they can also demand, generate the demand on the ground level. So, Carol, just to kind of go on, we are talking about the integrated services. How do these affect, if they do, the health-seeking behavior of people in our communities? And how would this integrated care support communities, affected communities, along their care journey?
So I think I'll start with the last bit of the question. Okay. Yes. The last bit of the question. So sometimes when you integrate care, it actually helps with the patient themselves. Because sometimes it avoids the stigma. For example, right now I noticed that there's a bit of stigma. In some areas, there's more stigma around TB than diabetes. So if somebody goes to a place and the service receiving is integrated, people do not know that when you go to this room, this is the kind of service that you're getting because it is integrated. Which is why for me, one of the goals is to have, like I said, so me for one of the goals would be to have, like, let's say, the mobile kind of clinics that go around that have all the services. Because when you walk in, no one knows whether you're going to be tested for HIV, for diabetes, and everything. And it also saves on time. So health-seeking behavior, you end up not going, like I said before, because there's so much time wasted. There's so much out-of-pocket expenses. So if I'm going to walk into a place where I know there's going to be double screening, I'm going to receive medication, maybe even something for my child, that would be helpful. But then even when we do the integration, for me, I think it should be the kind of integration that actually works. We've had situations where there's been integration talked about on paper, where sometimes our governments have these very good documents that talk about integration. But for us who are on the ground, the integration doesn't work sometimes. But on paper, it's there. But we want a kind of integration that will have the actual impact, something that is going to support the communities who go out to access it. Is it still me? Yeah, so yeah, for me that would be the health-seeking behavior would go down because of the extra expenses, but then if you integrate, I think you tend to get more people coming because people don't want to go to be seen to 4 or 5 cases. I always give this example. So here I am, I'm Carol. I've mentioned all the diseases I have. I don't want the health facility or the Ministry of Health to fight over me. Diabetes pulls me this way. You cut me into pieces. HIV pulls me this way. TB pulls me the other way. Malaria pulls me. Take me to one spot. Take care of me. I'm one person. So that happens to a lot of people. So if that can happen, let me go and get my diabetes testing. Let me go to if I have TB, my TB medication, my HIV clinic. Let me do everything in one time. Don't send me to 5 multiple places.
Yeah, thank you.
Blessy, you've been in advocacy for a long time. So how has your career in advocacy and your engagement with civil society organization driven improvements for the TB patient experience? For example, can you please share what lessons you can share today with this audience here? to scale up successful models of integrated care. Any models that you have, please share with the audience.
Yeah, thanks, Carol. Great question. I love to answer. I want to share with you a success story. We both talked about stigma, and we know that TB and even diabetes, there is a lot of stigma associated with that for different reasons, but there is stigma. So at the Global Coalition of TB Advocates, about 6 years ago, we started, kind of highlighting that there is stigma in TB, but everybody kept on saying, no, HIV is the one with stigma, TB has no stigma. And yet we were hearing from people on the ground. So we went ahead and we spoke to women across the globe and captured their stories and put it into a small booklet. It wasn't a project, but we did it because it was a need. And then I carried some of those books to the UN high-level meeting in 2018. Teresa is here. At one break, we grabbed all the powerful women like Teresa, Luchika, others, and we launched it. The Women and TB Stigma Stories. And people said that we couldn't read it without crying. It was so powerful because it was the words of the people on the ground who had experience. So then the next, following that, the UN Secretary General's report had stigma and discrimination as one of the top 10 recommendations. So you build it from the ground up, and then you take it back to the country level. So we took it back to, I'm from India, so I took it back to my government, my national TB program, and I said, we have the highest burden. Stigma is a big barrier. Let's do something about it. So they said, okay, can you develop a national strategic plan for Government of India to address stigma and discrimination associated with TB? So a group of 6 organizations came together and we developed it. And we went on to develop a training module on that. And we are in the process of training the National TB Program, state-level officers, district-level officers, other NGOs. So change happens, but it needs to be built from the ground. And I hope that even with TB and diabetes, which we cannot not, bring together, we would be able to highlight that lived experiences. Both of us have diabetes, and so we know what it means. But I think that kind of community engagement is very much needed. So, Carol, drawing on examples witnessed during your experience in advocacy, can you tell me about what this effective, I know you have already mentioned it, but how would an effective integrated care look like? And how can we incorporate that to have patients and community input into it?
So like I said before, I think the one-stop shop is what would definitely work. That has worked TB. That is because, for example, I'll give an example. When we work with our communities, when we started the TB HIV integration, we would go and sensitize the people living with HIV to say, when you go to the health facility for your clinical test, demand for a TB test. So from the beginning, they actually know it is free and demand for it. If people don't know that there's a service that's available, they're not going to demand for it. So the one-stop shop is important, but the community should have that information. The main one also, like I always say, let's not reinvent the wheel. HIV has done it, TB has done it. Let's pick lessons from that. And include the recipients of care at the center of the response. I've noticed that we have a lot of people working around diabetes, but it's really diabetes type 1, type 2. There are very few people. So let's have champions. Let's have people speaking. In TB, we have, we work with the TB caucus. For example, my organization is the Secretariat for the Zambia TB caucus. So we use that space to demand for issues around TB. For example, I was talking to my colleagues at dinner yesterday to say, if I speak to 10, 20 MPs in my country about something that we want to get around TB, and the 10 of them or 20 of them go to Parliament and ask for them. If it's a bill, it will pass. So if that can happen again, we have champions around high-level champions. But also, let's not leave the recipients of care. They live the disease. They feel the disease. It's easy for them to create demand. It's easy for them to go to a government and talk about having, let's say, the strips reduced or any other areas. So for me, for that part, it's really important to put the patient at the center of the response. We all know in HIV, that's how the treatment came on, because people living with HIV, we went to the streets, we marched, we screamed, and that's how we got the treatment. So we can bring that to diabetes as well. So finally, Blessing, in future, what progress do you hope to see in integrated care? And also at the same time, what roadblocks remain?
Thanks, Carol. So, people like me, a TB survivor working in the TB field, we've all committed to ending TB by 2030. And we need to do everything in our power to ensure that happens. So what does the future hold? Exactly like what you said, treat me as a person, holistically. I don't want to run around between clinics and departments. One-stop shop, provide the care that I need. If I go for my diabetes testing, test me for TB, vice versa. Referrals, put me on treatment that is needed. Somebody mentioned people-centered care, person-centered care. I think that's the full meaning of it is that the person doesn't need to run around and can get the services needed at one place. Roadblocks and challenges. I'll talk about TB. It's a very top-down, medicalized, vertical program. It has changed over the years, but still we need to make sure that it's very flexible. Diabetes services are not easily accessible still. The costs are high, and there needs to be some sort of community engagement, and stigma needs to be addressed. So we need to learn to work together, and funding is extremely important, understanding the need for resources to implement this on the ground level. So thank you very much.
Thank you, everyone.